My name is Tracy Rabin, and I'm Director of the Office of Global Health in the Department of Internal Medicine at the Yale School of Medicine. I'm also the co-director of the YIGH Global Health Ethics Program. And it is truly an honor today to be able to introduce you to the featured speaker for our very special YIGH event, Dr. Olusoji Adeyi. Dr. Adeyi's career accomplishments are truly impressive. Before I share a bit of his background, I want to summarize by saying that if the true measure of our successes are the number of lives that have been changed for the better because of one's efforts, both direct and indirect, then he is among our time's most eminent. Dr. Adeyi is currently the president of Resilient Health Systems, a Washington, D.C. based policy analysis and advisory services firm. And he's also a senior associate at the Johns Hopkins Bloomberg School of Public Health. Over the course of his more than 30-year career focusing on global health policy, he has held leadership positions with the World Bank, World Health Organization, UNAIDS, the Nigerian Federal Ministry of Health, and was the founding director of the Affordable Medicines Facility Malaria, a public-private partnership hosted by the Global Fund to fight AIDS, tuberculosis, and malaria. With a focus on improving the structure and function of health systems, these positions have allowed him truly to touch every region of the world. Born in Nigeria, Dr. Adeyi earned his bachelor's in medical degrees from the University of Ife and subsequently received a Master of Community Health from the Liverpool School of Tropical Medicine, a Master of Business Administration from Imperial College London, University of London, and ultimately his Doctor of Public Health from the Johns Hopkins University. When we spoke a few weeks ago, he shared that it was his early work as a physician that motivated him to pursue additional training and to set off on this very unique journey. In that role, he had the personal experience of seeing the devastating impact that financial policies, influenced by national priorities and international donors, had on patients and the health system. And as he told me, I wanted to be in a position to influence policy rather than being on the receiving end. Along those lines, he had also shared the perspective that it's important for those of us who seek global health careers to embark on this journey for reasons that are personally meaningful, as this is what will stiffen the spine and keep us moving forward in the face of adversity. I'm certain that this sense of purpose will come through in today's conversation, and I look forward to the other lessons that he has to share with us. Dr. Adeyi, thank you so much for joining us here today. I'll turn the podium over now to the moderator for today's Q&A session, my Yale School of Public Health colleague, Rafael Perez Escamilla, Professor of Public Health and Director of the Office of Public Health Practice and the Global Health Concentration. Looking forward to a very robust conversation.
Thank you so very much, Tracy, for your kind introduction. And Soji, what an honor to be able to serve as a host today for you to share with our audience. Why did you decide to take the somewhat painful step of writing a book to actually share your experiences in global health? What is the niche that you tried to position your book when you decided to write it?
Thank you very much, Tracy, for your kind introduction, and Rafael and your team for this opportunity to have this conversation. You referred to the process of writing the book as painful. That's true. I think there are two other dimensions to it. One is it was actually a joy because it was so instructive writing the book. And this is the book I wish I had when I was 25. And I've written it several times in my mind, but I finally had an opportunity to put it on paper. So what is the motivation behind the book? The ultimate motivation is for those of us who are engaged in public health, whether as policymakers, as analysts, as financiers or influencers, that we step back, re-examine the roots of global health, take stock of what has worked well, and importantly, honestly appraise why it is so unhappy today, why global health is so unhappy. But that we do so not because we want to then slump into negativity that nothing can ever improve, but so we do so with a renewed sense of purpose and clear-eyed optimism that we can make it better. That is the ultimate purpose of the book, and which is why my favorite sentence in the book is actually the last sentence in the book, which says, "A brighter future is possible."
Thank you very much, Soji. And I do want to share with you and the audience that I worked for 3 years in your beautiful country of Nigeria in the state of Kaduna with maternal, infant, and young child feeding project. And through that project, I learned on the one hand, how complex Nigeria was and is from political, economic systems, healthcare systems, education systems point of view. But at the same time, I also learned about the incredibly rich culture and traditions and quite frankly, experiences that the country has had over many, many decades now, trying to improve a number of healthcare outcomes that are not only unique to Nigeria, but also to the rest of the world. So can you tell us a little bit about how having been born, raised in Nigeria, actually ended up informing your decision to end up working in the field of global health, to do it from a capacity building perspective? And lastly, what have you learned from your own experience with regards to the legacy of colonialism and neo-colonialism on current global health inequities?
Thanks, Rafael. And now that I know you are my fellow Nigerian, I think one of these days you and I should get together and share a glass of palm wine, which I'm sure you had when you were in the country. But on the topic at hand, in hindsight, it's all very clear now in hindsight. Much of what I do is influenced by my own early experiences and some the formative years in Nigeria. Excuse me. My mother is a retired businesswoman. My father was a nurse. So I saw quite a few cases that he treated early on. And there's one that sticks in my mind. He was extracting guinea worm from somebody's leg. And that was quite impressive for a 5 or 6 year old to witness. But in the larger social context, I grew up in a society with its own very powerful narrative. I was born in Oyo, which is the capital of an old empire that predated many of the countries we're talking about. It predated the United States, for example. And Oyo is called the land of Shogo, the god of thunder. So we had a very strong sense of our own social identity. I also did my undergraduate years in Nigeria. And I went to medical school there too. And what I experienced there was the power of education and the stresses that poverty can put on those who cannot afford the healthcare that they need. I think that was a very searing experience to witness as a young physician when I witnessed that. But I also come from a background in which we were taught from day one that you have to do something about the world around you. You're not just going to complain about it. So I opted to go into public health policy as a result of that. Well, when I look back now, I think 2 or 3 things stand out to me. The importance of a sense of purpose. This is for positive reasons, because it keeps us going. It keeps us going on a day-to-day basis. It also makes us more resilient to the various ups and downs that we experience in the course of a career in global health. A second one is to pay extra attention to the realities of people with whom we work in low and lower middle income countries. They have their own narratives. They may not have studied epidemiology and biostatistics and health economics. And so some of the things they do and some of the ways they go about things may not make sense to somebody who has just parachuted in from the global north. But if one has a certain degree of humility and a willingness to learn, then it becomes possible to understand their reality. It becomes possible to engage with them in a very effective way, and it becomes possible for the programs on which we work, the analysis that we do, to actually have a multiplier effect.
Thank you, Soji. And as part of the subtitle of your book, you list investing amidst pandemics, denial of evidence, and neo-dependency. Can you talk to us a little bit about what do you mean by denial of evidence as well as neo-dependency, and why are those important to understand and address?
Thank you, Rafael. In our profession, in public health policy, one of the tenets is to rigorously base our recommendations and our programs on scientific analysis. Of course, you adapt from country to country and even within countries so as to be viable during implementation. And I think this is great. It's central to what we do. It's central to our professional credibility. However, if you look at the world around us in global health, that premise does not always hold up. So let me answer your question directly. One of the things about which I've been most impressed in my career is the extent to which evidence is swept aside when it does not meet the preferences of powerful actors in global health. There are many examples of those. And I refer to a few in the book, but the one that is really central to the illustration in the book is that of the United States Agency for International Development, USAID, and the US President's Malaria Initiative, USPMI. This is concerning access to malaria medicines for people in low-income countries. Despite rigorous evaluation of a pilot program, that in fact the approach taken was working, USAID and USPMI did everything they could to derail that program. They bullied any entity that did not subscribe to their point of view, and they successfully bullied the Global Fund to fight AIDS, TB, and malaria into discontinuing that program. Now, I'm not telling you any state secrets. It just happens that I led that enterprise, so I had a front row seat into what happened. So this is an instance in which USAID and USPMI simply obliterated a program that was demonstrably on the path to saving many lives in low and lower middle income countries because it does not conform to their preferences. And because if it worked, in my understanding, since it was demonstrated to be working, it was a threat to the way USAID does its business, which is to give hundreds of millions of dollars contracts to American-based contractors. And if that program were expanded and institutionalized, as it should have been, that would really put USAID's business model in turmoil. So that is a prime example of denial of evidence. I should state, by the way, that at the time that program was evaluated, it was probably the most rigorously evaluated large program in global health around that time. Now, on neo-dependency, let's be upfront about one item, which is that colonialism was extremely bad. There's no other way to describe it. Crimes against humanity were committed by European powers and by those who enslaved Africans. There's no qualifying it, period. And it is also true that the effects of colonialism are still with us in terms of the fact that the colonized societies, even though they're now politically independent, the wound endures in terms of their social policies and the devastation that was wreaked over the years. Having said that, my proposition in the book is that a greater problem, a problem that is greater than neocolonialism and the lasting effect of colonialism, is what I call neo-dependency. That's the dependency or the perpetual dependency of many countries in the global south on the global north. And this is manifested clearly, but not only, in the way foreign aid is mediated by several institutions, and in the way those countries, it's as if they really do not want to graduate from being dependent on the global north. And that if this is going to be turned around, then there needs to be a fundamental change such that those countries become more reliant on their own revenues, on their own domestic resources, and that they demonstrate what I will call increasingly self-financed assertiveness. That really is the core of it. So while the bad effects of colonialism endure, the central problem, as I understand it, is actually that of neo-dependency. And that leads to several recommendations in the book.
Thank you very much, Soji. And I do want to ask the audience to please take opportunity take this opportunity to engage with Dr. Soji on some questions and answers based on these very thought-provoking and important statements that he's making. So,
Raphael, we do have one question that came in.
Please.
And the question is, how do we as students and staff at Yale or other powerful institutions in the global north advocate and work in mitigating the negative effects of neocolonialism in global health?
Wow, that's $1 trillion question and a great one. I think before advocating, my sense of it is to be very deeply aware of the narrative around us and how those effects of neocolonialism are modulated in real life. So it starts with the courses in those schools. My sense is that while epidemiology and biostatistics and the behavioral sciences and health economics remain central and core to a rigorous curriculum in public health, for example, it is important to pay equally serious attention to political analysis, to the political economy of global health, and to what I will call influencing policies and enabling change, so that we do not go into a highly political situation with purely technocratic tools that assume that if we just get our regressions right, then everything will fall in place. That's the first one. The second step is taking the time and making a serious effort to understand the socio-political narrative and the socio-political realities of the countries in which we seek to operate. Let me share an example that is in the book, in this book, Global Health and Practice. I lived in Ethiopia many years ago as a young professional working with the World Health Organization. And I was there during the war that ended in 1991. One of the things that I observed was that many very senior technical experts who had been trained in really high-class high quality schools of the likes of Yale and all the others, they will come into the country, and a number of them will look at their counterparts and they will see the stereotypical poor citizen of a poor country, or poor official, an official of a poor country that needed help. And they promptly proceeded to prescribe solutions to those officials. Now, they were doing so with the best of technical or technocratic intentions, if I may use that phrase. The problem was, it did not fit the narrative of those officials, because the officials looked in the mirror and they saw the descendants of those who won the Battle of Adwa when the Ethiopians defeated the Italians. And this was, in addition to that, they remember the association between the Queen of Sheba and King Solomon. So when they looked in the mirror, they saw the descendants of a very proud people. And you can just imagine how these two narratives collided. And that limited the effectiveness of those Europeans and North Americans to whom I referred. So taking the time to truly understand the narrative and the socio-political dynamics of the people with whom we are engaging is key. A third one is to be very clear in terms of what we're optimizing for. If we're optimizing for a small pilot project to demonstrate effect in a population of 500 people or 5,000 people in one sub-district, it's a legitimate thing to do. But if our aim is to engage with and influence what happens all across a very large country, like Pakistan or the Democratic Republic of Congo or all of Nicaragua, just to cite 3 examples from different parts of the world, then we need to understand that we're engaged in an enterprise that is substantially political and proceed as such.
Thank you very much, Soji. And we're doing our best at the Yale School of Public Health to actually update or develop new courses to very strongly emphasize the points that you just made about how, yes, small-scale efficacy trials or studies are important, but the ability to transfer that crucial knowledge for the survival and healthy development of human beings into large-scale sustainable operations is another ballgame, and really requires a deep understanding of the history, the political, the economic, the social systems in the countries. And as I found very rapidly in Kaduna, in Nigeria, and really understanding how powerful the community structures are, and how impossible it is to scale up anything if there is no support from the community leaders for those projects to end up being implemented successfully on the ground. So I really want to urge the audience to read this very important book on global health practice, because it really comes from what I like to call a huge global health practice scholar that has been there, has done that, and has been able to look at the global health challenges from many different angles over several decades. So please keep on sharing with us your very insightful questions. So moving on to the next part of the discussion, Soji, as you know, given the context of the uncertainty with the COVID-19 pandemic, the likelihood that it's not going to be the last, probably at least in my lifetime, some of our students, even our faculty, are a little bit anxious about how the future jobs in global health are going to look like, which are the skills that the future global health professionals should have to be successful doing their work. So can you share with us the contributions from your excellent book towards institutions like Yale to convey to the faculty, to the students, in terms of what they should be focusing on to really strive to become, really key global health practitioners moving forward?
Thanks, Rafael. I think probably the single most important question to ask oneself is, how can I be most useful? And that may sound so obvious, but I think a failure to closely reflect on that question might lead to a lot of frustration. So if one approaches it from the point of being useful, then it means go where the problems are and be equipped with the tools to help better understand those problems and to help formulate workable solutions to those problems, even if they are not the ideal solutions from a purely theoretical point of view. So let's unpack this. In terms of being useful, perhaps because of the COVID-19 pandemic and the subsequent attention to global health, for people, younger colleagues who are about to go into the field, I would say you're actually very fortunate, because you don't have to explain to anybody what public health is, or you don't have to explain to most people what public health is or why it is so important. Now everybody gets it. Okay? In order to be useful, I think one also needs to figure out which niche to occupy or to seek to occupy initially. So is it to be an analyst, helping to better understand the scale, the dynamics of health problems? Is it to be primarily a doer? And I'm not suggesting that those are very different. They're intertwined. In which case, it will make sense to seek opportunities in entities implementing programs in challenging situations and to go with the intention of learning. Or is it to be primarily in an advocacy position? Again, that's not separate from being an analyst or a doer. I'm just trying to simplify. And that's okay too. And then it means understanding whether one is seeking to be an analyst in terms of bearing witness, which has its place, or whether one seeks to go beyond bearing witness and nudging rich and powerful entities to do better by the developing countries, or nudging the rulers of developing countries to do better by their own societies. One final note on that is overarching. Charles Houston, who was the professor of Thurgood Marshall at the Howard University Law School, which is just a mile from where I'm speaking in Washington, D.C., had an injunction for his students. And he said it was not sufficient to be a lawyer. They also had to be social engineers. Otherwise, they were just being parasites. I think that applies to people in global public health too. In different ways, it's important to have the mindset of a social engineer, an analytically rigorous social engineer. Otherwise, one might unwittingly become a parasite. So in sum, the future is bright for those entering global health. There are just so many challenges waiting to be tackled. And please go forth and be useful.
Thank you so very much for such an inspiring answer. And Abel Galeta is also asking, given the complex skills essentially that are needed here to succeed in in the field of global health, how do you overcome the challenges that inevitably you're going to find as an early career professional? What did you do to overcome those challenges yourself? What words of wisdom your book has to offer to Abel and colleagues?
Well, I really appreciate your question. This is Abel Galeta, if I'm looking at the chat box. Great question. I think it's important to have good mentors, because when you are starting out, there are many things that are just so new and they can be confusing, and sometimes you might struggle with how to prioritize and what to filter out. So having a mentor or a set of mentors, in my view, is really important. A second one is approaching global health with a mindset that every obstacle is an opportunity to learn and get better and grow. I think those two are really they're fundamental. Yeah, those are the two key ones that I would say. Early on, having good mentors and approaching obstacles from the perspective of learning. I think those are critical.
Yes, thank you, Soji, very much. And then linking this somewhat to the previous statement that you made about, the U.S. Agency for International Development, which is, as we know, is not unique to USAID. It's a very common situation with international aid agencies and the fact that they all have their agendas, their priorities, and sometimes from almost overnight, they change, and countries that are being affected by huge problems and working of them for decades do not have a say on when and how those pivot points happen. So several of my students, have asked me in the past, is there any hope that I can actually work for an agency like that and change it from the inside out? If I choose not to work in an agency like that, then where am I going to work? Where am I going to be able to make a difference? And I get very well your important point about advocacy and grassroots work and so on, but also in the context that financial resources are needed as well to engage in large-scale programming and so on. And what would you advise our students regarding the sense of hopelessness that some of them have, that it's very difficult, will be almost impossible to change the way the key agencies are governed, the structures that they have, and the somewhat arbitrary way in which that they follow to make decisions?
Yeah, Rafael, I would say they are very complex institutions. And within that complexities, there are opportunities for professionals who are rigorous, who are discerning, and who are committed to making a difference. So even for younger members of staff, it means being very credible in one's own analytical work and developing a way of engaging with more senior people in the institutions to inform their thinking and to change the way they look at problems. And if that change means a 25% improvement over what they would have done before, that's a win to start with. But at that stage, for the entry-level professionals, it means their span of control is relatively narrow. That's true. But over time, you get a much broader and increasingly a bigger span of control, and therefore the scope to influence decisions and influence policies becomes even larger. So I can share a few examples with you. There's a chapter on Russia in the book. And yes, I led the team that did that turnaround, I also had a vice president at the time for the region who was supportive of the effort that we made. So that's a positive aspect. And there were several other aspects in which I was involved, both analytical work and program implementation and financing, etc. So it is not a case of black or white, that the institutions are absolutely irredeemable. I think it's the case that they're very complex, and within that complexity, there are opportunities for public health professionals to make a serious difference. Having said that, in terms of the macro system, realigning the macro system, etc., well, that is beyond the purview of any particular individual in global health or agriculture or transportation, whichever sector you primarily work in. That becomes a political question in terms of the global financial architecture, and that is part of the point in the book. So please, if you are wondering, is it a hopeless task to work with or in those large agencies like WHO, the World Bank, etc.? No, it is not. There are vast opportunities there, and I will seriously encourage you to seize those opportunities.
Thank you very much, Soji. And for the audience, please, if you want to share with Soji any personal experiences working for agencies or in the field, your academic institutions, and so on, and what have you learned from them, we would very much welcome your sharing of those experiences. So I want to move on now towards the last phase of our conversation, which is related to how to maintain initiatives, how to maintain traction, how to ensure that the relatively few programs that have been successfully scaled up across countries essentially keep on going, and they don't fall back, to the chaos that was there before they emerged. So in terms of sustainability of programs, what lessons does your work offers to us?
It's a great question, and perhaps is the perennial question. In my experience, I think programs become sustainable on multiple dimensions. Quite often when we talk about sustainability, we're talking about financial sustainability and technical sustainability, both of which are highly important. There is another dimension, which is political sustainability. And for the median leader, a program is sustainable when the perceived political benefits of that program, of continuing that program or enlarging it, when they outweigh the political risks of not continuing it. Which is why it is very important for the political leaders in societies to be directly engaged in and to own large programs in their own countries. It's also very important for the citizens of those societies to see and feel the benefits of those programs. If the benefits of a program are obscure, well, there's unlikely to be much social mobilization behind it. But if they are visible, they're actually communicated to the public, and the successive governments know that these programs are actually delivering good things, then they're more likely to at least make an effort to continue those programs. There's a little dimension that I would like to draw our attention to, and this is the compared to what question. So if you engage in a large program, and just for discussion's sake, let's just say the success rate before you went in was 10%, and you are able to take it to 60%, obviously that's not perfect. Okay, you really want to hit something much higher. All other things being equal, I think it is wise to celebrate that improvement from 10 to 60%, and then seek to take it to 70%. But sometimes in global public health, I have seen situations in which if it cannot go from 10% to 100%, then you have many advocates saying, okay, it's a failure, it's bad. So it's a binary situation, which is just so self-defeating. So again, for all of us going into this field, or those who are there and seeking to make even more improvements, let's keep this in mind, the compared to what question, because quite often the counterfactual is not utopian perfection. The counterfactual is actually something that is a really bad situation. So if it's getting better, celebrate it. Don't be complacent. Don't be satisfied, but celebrate that success and just keep pushing ahead. Don't just throw it all away because you cannot achieve immediate perfection.
Absolutely. So you couldn't, well, I say absolutely. I myself, in my experience, I couldn't agree more, because I really think that goes back to your point of the importance of understanding the complex causes behind these problems, many of which have been with us for centuries, and that we need to be realistic as to what is a temporary solution, what is a short-term technical solution, what at the end of the day would be a real long-term solution. So if everybody is contributing in a coordinated way, I think, with their 10 cents, so to speak, to improve, then it reaches a point where those improvements are not that trivial and cannot be discounted. So Pranav Savanur has a very thoughtful question for you. So how can we build a sustained and non-partisan political will and commitment for global health financing? And he has in mind the upcoming funding renewals for programs like the Global Fund, Gavi, the World Health Organization, and so on. How to separate politics from the true mission of global health, is a way I understand this question.
Yeah, great question, Pranav. First, politics cannot be separated from it. I think what can probably be separated from it, or what we should make an effort to separate from it is toxic politics. Okay. Now, on the substance of the question, I think for entities like Gavi and the Global Fund, the real challenge, as I see it, is how they will replenish to transition and exit from what they are currently doing in the way they are currently doing it. So what will it take, for example, such that 8 years from now, say in the year 2030, the countries themselves are the dominant financiers of those basic health commodities and of those basic health services that Gavi and the Global Fund disproportionately finance today. So if you take a specific, just take a specific example, let's just zero in on malaria. Last year, WHO recommended widespread use of the RTSS malaria vaccine, the first time it's done that for a malaria vaccine on a large scale. And normally one will expect that since this disease has been around for millennia and is such a big problem, the leaders of the countries will lead and commit to funding the purchase of those vaccines predominantly by themselves. Instead, what happened was that Gavi announced that it was going to commit, I think, about $156 million over the next few years to those vaccines. Now, for a child who gets that vaccine in Zambia or Liberia or wherever, is that a bad thing? No, it's a good thing. The problem is the following. Gavi was substituting itself again for the leadership, domestic leadership in those countries. And that was very poor judgment on the part of Gavi. Okay? Still on malaria, the very last estimates from the World Malaria Report published by WHO indicate that 2/3 of the expenditures on malaria control and elimination come from external sources. That's 2/3, 67%. So this needs to change. You cannot have a situation where permanently there is dependency on external financiers. So for replenishment, it should be replenishment for transition, not replenishment for self-perpetuation. That's the real key here that I really want to have on. So that applies to Global Fund and Gavi. As for WHO, I really am not convinced that a replenishment model is the right way to finance WHO. Is the central health leadership agency, the technical normative agency as well. And it seems to me that having that core financing sorted out is key. I don't think that also means WHO should be responsible for everything or try to do everything under the sun in health. It does not mean WHO has to attend every single meeting in every single village on health. So there's a case to be made for concentrating the effort on WHO on some core functions and for funding them well through assessed contributions to the regular budget, not extra budgetary allocation. Back to you, Rafael.
Yes, wow. I think we could stay here for 3 hours speaking with you. What an engaging and thoughtful conversation. And I feel like really everyone should read Soji's book. Not many people have the very, very holistic experience that he has in global health. Sumaira Akbar-Sada wants to thank you very much for your talk. She finds it very inspiring. She just went to Amazon and ordered your book so that you know, and she can't wait to read it. So I'm very, very glad, Sumaira, that you got inspired to do that during this conversation, and I'm sure Soji will be very happy to sign your book when you get it. We can easily arrange for that, I think. So Soji, to wrap up the conversation on my end, I really get your very central message here. It's loud and clear. Unless governments end up being empowered to own the systems, the structures, the infrastructure that is needed to improve public health within their countries, and to do so with equity, following human rights principles, social justice principles, and so on. It is very difficult to actually see how improvement can be made on a global level. We know that oftentimes there is this tension between governments feeling, oh, NGOs know how to do it, they're really great at doing it, have them do it. NGOs saying, we cannot do this on a national scale, we cannot keep this sustainable. And oftentimes, to me, it becomes an absurd either or argument. I really think that there is a very special place for NGOs as part of a new global health governance system. But at the same time, there is absolutely no reason why they cannot be part of a government strategy when the governments own, the programs, the policies, and so on, to keep on working together. So what can do? I mean, do you agree with that or not? And what can be done to improve that very, very interesting dynamic that I think needs to be addressed to improve much more public health across the globe?
Yeah, Raphael, I think you touch on an important point. There is no viable substitute in the medium term for a responsible government that leads policies within its own country and works across sectors within its own country. And that includes financing, of course. But there is a difference between public financing on the one hand and public delivery on the other hand. So it's entirely possible. Most systems are mixed anyway. It's entirely possible for most of the expenditure in a country, most of the health expenditure in a country to be publicly financed, but for services to be delivered by a combination of public facilities, not-for-profit NGO facilities, for example, and for-profit facilities who might be contracted by government to deliver those services or contracted by a health insurance agency to deliver those services. And there is a serious role for civil society to play in that, the NGOs and the CSOs, if one wants to delineate, both in terms of keeping government honest, if I may use that expression, mobilizing the society and shining a light in otherwise dark areas. But the NGOs and CSOs, in my understanding, do not substitute for those core governance, policy, and policy translation functions that can only be done by government. And I will even go further and say one thing. In my experience, both the country-based NGOs and the international NGOs in different places have made really serious contributions to health service delivery, including in some very hard-to-reach places. At the same time, it is the case that some of the northern NGOs, not all of them, some of them sometimes, unwittingly perhaps, try to substitute themselves for the government of those countries. So they don't like international organizations to dictate policies to countries, and they are right. International organizations should not dictate policies to the countries. But in my experience, quite a few of those NGOs would like international organizations to dictate the NGO's preferences to the countries. And that needs to stop. In addition to that, quite a few of those international organizations do the countries a disservice when they blame international financing institutions for everything, because that infantilizes the governments of those low and lower middle income countries. It's as if the governments cannot think for themselves, they cannot make decisions for themselves, and it becomes very convenient to just blame everything on outsiders. So in that regard, I think quite a few of the large northern NGOs need to do some introspection and avoid a situation in which they position themselves as if they are the legitimate representatives of those large populations in low and lower middle income countries. They are not, and they cannot substitute for those people. I also want to thank our colleagues who have sent text messages. I think Shedrack also, thanks for getting the book, and I look forward to engaging with you all. Please feel free to join me on Twitter. Back to you, Raphael.
If I can squeeze in one last question,
please.
And I apologize for those that I cannot ask your questions, but But I think this is a wonderful one to wrap this conversation up. And it comes from Edwidge the JASA, and it's about what does the future hold for healthcare systems? You know, at the end of the day, as Edwidge states, in sub-Saharan Africa currently, almost no country meets the World Bank and WHO benchmarks for universal health coverage following the SDGs 2030. And in the context of what has just happened or is happening with COVID-19, what is the future for healthcare system strengthening for that agenda?
It's a great question on which to wrap up. I agree with you. I think the COVID-19 has been a clarifier, or it is a clarifier. It's not yet over. And it's brought a lot of stress on societies. On the positive side, it has also made clear the importance of self-reliance by countries of the global south. Because what has happened during COVID is you realize when COVID struck, let's face it, the message from the global north was, look, you are on your own. So what does this mean? It means the global south needs to face its reality when it comes to universal health coverage. Nobody from outside is going to solve it for them. So, my mind, the way to approach this is what has already been described as progressive universalism. Start with an emphasis on a core of essential services, what some people refer to as essential package of services or essential health package, and try to get this to the whole population. I think that is really key in all our conversations. So that's number one. A second pillar of this, in terms of how to finance it, is to move away from systems in which many countries, a large proportion of financing comes from private out-of-pocket expenditures, which is very regressive. It's not equitable. It causes financial hardship. And to move more towards publicly financed health systems. But that also means doing better in terms of domestic tax collection. Many of the countries do very poorly in terms of collecting their own taxes. These are two of the pillars, not all, these are two of the pillars required to make progress towards universal health coverage. There's a paper that I wrote about 4 years ago with some colleagues. We called it the economic transition of health. And I think we tried to unpack, in fact, we anticipated some of these constraints that have now arisen. Great question, Edwidge.
Well, on that note, please join me in warmly thanking Soji for the wonderful contribution he has made through his career, crystallized in his book, and for agreeing to have this wonderful conversation with us today. Thank you very, very much, Soji.
Thank you, Raphael and colleagues. Thanks, everybody. I really appreciate this discussion with you. Thank you.
Thank you.